Okay, in this fourth block, which is a fairly brief number of slides, we'll talk about the hormonal agents used in oncology therapeutics. Probably of all of them, these are the least toxic and maybe the most familiar drugs, although they have their own sets of side effects. We focused on most of these agents elsewhere in the curriculum. Glucocorticoids we talk about certainly throughout the program or the curriculum. And androgens and estrogens and their antagonists we speak of more in men's or women's health. The aromatase inhibitors sort of fit more here than they do in other areas as well. So, sort of a couple of slides here, just to sort of a quick sort of review, is prednisone, dexamethasone, glucocorticoids. We'll use these sometimes as adjunctive therapy to suppress inflammatory situations that contribute to certain cancers or affect cancers. They're sort of limited in when we use them, with the exception maybe of dexamethasone, which we also use as it relates to nausea vomiting management, which we spoke of briefly earlier in the cytotoxic management section of the GI. It's not common that we use androgens directly, although occasionally we'll see androgens used in breast cancer and androgen antagonists used for prostate cancer. And that's a particularly the androgen antagonists are more commonly used in prostate cancer than are androgens in breast cancer. But both of those are pretty sort of common modalities to think about and why they work, in that breast cancers are often sort of fed by estrogens, but particularly prostate cancer fed by androgens. And so using the androgen antagonists has become pretty standard in prostate cancer management. Similarly, the gonadotropic releasing hormone agents are used in prostate cancer as well. And these are pretty common, particularly Zoladex and Lupron are sort of standard in those regards. They have other indications as well. As far as giving estrogens, it's pretty rare to give estrogens in any situation for cancers, particularly the only indication might be prostate cancer, and even that's pretty unusual or unexpected. It was historic that first-line therapy in many estrogen-sensitive breast cancers that we would give tamoxifen, which is a selective estrogen receptor modulator. And it's still used. Tamoxifen is still used for that purpose. Less so now, though. It's really second line to the aromatase inhibitors that are farther down here. And really, it's the aromatase inhibitors that are first line in breast cancer, depending on the receptor type. And at the very end, in the last 6 segment, we'll talk a little bit about where aromatase inhibitors fit in breast cancer management. Not a lot, but a little. So we'll see the aromatase inhibitors probably of all of these therapies. Aromatase inhibitors as a standard for breast cancer, certain subsets of breast cancer management, and we will use the androgen antagonists in prostate cancer. The aromatase inhibitors specifically, they deprive breast cancers of estrogen. They're usually well tolerated, and they're usually used in conjunction and sequenced at a certain point in time for estrogen receptor positive breast cancer patients. The older anti-estrogen tamoxifen used to be the standard here, but it's now sort of second line or after 5 years of aromatase inhibitors. Briefly, the glucocorticoids are used in combination with other drugs, either for their anti-inflammatory effects or to treat the adverse effects associated with therapeutics. Most commonly, we see dexamethasone used in highly emetogenic regimens. And finally, high-dose corticosteroids, all the things we talked about earlier in the year about glucose intolerance, changes in mental status, fluid retention, and then with the estrogens, particularly concerned about thromboembolic risks, which one of the reasons why we don't use estrogens very often, because their efficacy is sort of limited. But that's in a nutshell the hormonal agents.